Good afternoon, everyone, and thank you for joining our webinar on the policy landscape of the upstream drivers of health. Upstream drivers are the non-medical needs of an individual and the community factors that contribute to health outcomes. Upstream drivers are sometimes called health-related social needs or social determinants of health, and these terms are often used interchangeably. Research indicates that an estimated 20% of health outcomes are linked to medical care, while the remaining 80% stem from these upstream drivers of health. This webinar is being conducted in parallel with the release of a new issue brief from the National Alliance to Impact the Social Determinants of Health, or NASDOH for short. This issue brief explores the recent policy changes impacting health-related social needs in Medicare and Medicaid and opportunities for states, providers, and other stakeholders to further these important screenings and services. We will share that link in the link to the issue brief in the chat in just a minute. And today we have a wonderful panel of experts for this discussion. First, we will hear from Sarah Singleton. Sarah is a principal at Leavitt Partners and an advisor for NASDOH. Sarah previously worked in the Senate and at HHS and will share with us about the federal policy changes impacting how stakeholders can address upstream drivers of health. Next, we will hear from Carter Kimball, who is a principal at Health Management Associates. Carter has held leadership level positions working in Medicaid and was previously the Deputy Secretary for Health and Mental Health for the state of Oklahoma. Carter will discuss insights from states addressing social determinants of health. Then we will get to hear from Caroline Fichtenberg, who is co-director of the Social Interventions Research and Evaluation Network, or SIREN. And she's also a research scientist at the University of California at San Francisco. In these roles, Caroline leads efforts to conduct, catalyze, and disseminate high-quality research on healthcare sector strategies to reduce health inequities and address social determinants of health. Caroline is going to highlight the current evidence base for addressing SDOH. Just a quick note that we are recording today's webinar and we will share the slides with everyone that has registered. We will leave ample time for questions at the end of the discussion, so please be thinking of your questions. And you can also ask questions using the Q&A function throughout this webinar, and we will try to get to those questions that you put in the Q&A function. Now I'm going to turn it over to Sarah Singleton to share with us about the federal policy landscape.
Thanks, Laura, and it's great to see everyone today. So just briefly to give you a word, Laura mentioned that she and I work with NASDOH, which is a multi-sector coalition that was founded in 2018 by a bipartisan set of leaders. Governor Mike Leavitt, who served in the Bush administration as Secretary of Health and Human Services, and Karen DeSalvo, who served as the Acting Assistant Secretary of Health during the Obama administration. When both of them left their federal government service, they had both worked on the transition to value-based care and trying to make the most out of our health system, and both realized that even the most high-performing health systems weren't necessarily seeing the health outcomes they want. And a lot of that, as Laura said, is due to the social drivers of health, the upstream drivers, the health-related social needs, which, as Laura said, are terms that are quite similar. I might use them interchangeably today. So they founded this coalition, which has payers and providers of healthcare, community-based organizations, patient and public health groups, business, and tech. So we work together in this NASDOH coalition to try to create the federal policy environment to address those health-related social needs. So today I'm going to give you a little bit of a flyover of the federal health policy environment. I only have a few minutes, so we're not going to get very deep on things, but I do hope you'll check out that issue brief that Laura mentioned. So let's go to the next slide. I'll start with this timeline, and I'm definitely not going to walk you through all of it. It's very crowded, and that's for a reason. This timeline goes back to 2017, the beginning of the first Trump administration, and through the end of the Biden administration. And as you can see from the color coding at the bottom, this reflects policies to address upstream drivers across Medicare, the Center for Medicare and Medicaid Innovation, which is CMMI, Medicaid, and other sort of health policies and White House level policies. And there's a whole range of different things that have been done through these payment programs, through discretionary grant funding, through waivers and flexibilities across different administrations to try to get at this core issue. So where are we today? If we go to the next slide, I'll talk for a moment about Medicaid. Medicaid is an obvious place to be thinking about the upstream drivers. It's a huge payment program, millions of people, low income, obviously, in many cases, implicated in one or more of these social drivers of health. So there's been a lot of attention over the past few years in trying to address upstream drivers through Medicaid payment policy. One of the major tools that's gotten a lot of attention is 1115 waivers. I'm not going to talk much about those because Carter is going to get into those when he talks about what's happening at the states. And waivers are, in some ways, really wonderful. There's a lot that you can do with waivers, and they can be very large in scale and they can be very innovative. But it's also a lot of work to submit a waiver application. And there's been some changes in policy from this administration where instead of the previous policy, which said, gave some pretty specific guidance to states about what the administration would welcome in waivers. At the beginning of this administration, that guidance was rescinded, and the administration said instead that they'll review waivers on a case by case basis. So we're beginning to get some more clues about what the administration is likely to support based on their other healthcare priorities. For states that don't want to go the full waiver route, there's still a lot of other authorities, such as in lieu of services, ILOS, which, if you're familiar with it, makes sense, and if you're not, is a very strange name. It's basically an authority to be able to provide something other than healthcare in lieu of those services. And that's an option states have to address a lot of these upstream drivers. There's also a lot of authorities that states have within their plans, and Carter's going to talk a little bit more about that. And then finally, Section 1915 home and community-based services waivers get less attention, but is another vehicle to be doing this. So I'd say the overall picture that I want you to walk away with is that Medicaid is still a really important tool in addressing upstream drivers. And even with changes in this administration, we cannot forget about Medicaid as one of the policy levers we have to address those. If we go to the next slide, another huge population with millions of beneficiaries is in Medicare. Through the payment rules during the Biden administration, we saw changes to start reimbursing for the time and effort that goes into screening for social drivers of health. This administration is moving away from that and the specific reimbursement for that. However, there are still some codes that are available for specific aspects of addressing social drivers in the context of medical care. The fee-for-service program is always a little bit more challenging on this front because you don't have kind of that one overarching area that you're paying for the coordination of care, since it's paying each provider individually. A place that's been very ripe over the past few years is in the Medicare Advantage supplemental benefits. There's special supplemental benefits for the chronically ill, SSBCI, is an area that has really grown over the past several years to provide seniors with a chronic illness with things like grocery assistance, home modifications, pest control, non-medical transportation needs. And we've seen a growth year over year over year in the number of MA plans that are offering those and the number of seniors and people with disabilities that are taking advantage of those. It's also been an area of a lot of innovation. Some of the plans are doing this with partners in ways that provide flexible use of benefits to really tailor to the beneficiary's individual needs. And then another area where we've seen a lot of exploration is in the CMMI innovation models. We're seeing that this administration has put out a new strategic focus in CMMI, and one of those big areas is prevention. We also know through the Make America Healthy Again, or MAHA agenda, there's a real focus on food and nutrition quality and exercise. And so we're beginning to see the models that are coming out incorporating elements of this. And we're expecting in the coming few months that we're going to see several more models released, and are hopeful that as they look at that, if you look at the total, package of healthcare services that are included in a model, that there is an element of upstream drivers included in those to really get at the factors that might prohibit somebody from seeking care or from having the best outcome. Let's go to the next slide. One of the ways, I've heard some of the people that I work with say, well, in this administration and with everything going on with Medicaid, it's not a time to focus on upstream drivers. And I actually really disagree with that. I think there's a lot of alignment with this administration's focus in several areas that play to working on these upstream drivers. So, one of those is in the area of rural health. And we have done a look at the state's applications for the Rural Health Transformation Fund, which is supposed to be awarded within the next week by the end of the year. And a lot of states, in looking at their transformation plans and what they're going to do in rural areas, are getting at the barriers to accessing care in rural areas, which often deal with the social drivers. So things like transportation, for obvious reasons, came up often, but also access to healthy foods and other social drivers. So I think that's one avenue where we're going to see states doing some innovative things with this new pot of funding. The other area to be looking at, and I know Caroline's going to talk about this more in her remarks, is food and nutrition is a major area of focus of this administration. And we're seeing across discretionary grant programs and also healthcare payment programs this focus on healthy food, nutrition, physical activity. And so it may be a time where it's harder to get new investments in things like affordable housing and some of those more expensive services. But when we're looking at that prevention agenda, the food and nutrition and physical activity are ripe areas. And then also looking at populations of interest. So I would say it's a time for stakeholders interested in engaging in this to think about, rather than doing a really broad waiver or a really broad program, what populations of interest might you focus on? For example, rural populations or veterans or people with disabilities. And so thinking creatively, if you're a plan or if you're a state, about how you might do some pilot programs or start in particular populations of interest that we've seen be the target of attention would be, I think, a good way to go. Next slide. So this is my last slide. I just want to draw out for you some of the key insights that if you check out the issue brief that was linked in the chat, you might find. As I said, there is still support for states on a case-by-case basis to try innovative things through their waiver applications. And then also using those other tools, particularly if we're addressing things that align well with administration priorities like food and nutrition. As I said, the Rural Health Transformation Funds, they focus on health-related social needs for specific populations. So that's an area to look at and to put on your creative thinking cap for. While opportunities in fee-for-service Medicare may be more limited, there's a lot more opportunities in Medicare Advantage, and so that's a place to be looking. And then finally, programs and demonstrations that emphasize value-based care continue to offer opportunities when you're doing bundled payments or value-based payments to address those upstream drivers. So it's very hard to give an overview of everything happening at the federal level, but hopefully I've given you a bit of a teaser of that, and you can look at more of that in our issue brief. And now I'd like to turn it over to Carter to talk a little bit more about what's happening at the state level.
Thanks, Sarah. I'm happy to be here with everybody today. Obviously, this is a topic that is getting a lot of attention, and I think some of it is really important given the shifting priorities and really more so the approach that Sarah kind of hinted to from the federal level. So my role today in this panel, and I'm looking forward to question and answer with you all, really is to give the state lens or kind of perspective as to how states are viewing these changing and the changing priorities and the shifting landscape. There are kind of varying degrees, if you will, as to the urgency for some of this shift that I'll go through, but I would really encourage folks to use the Q&A feature, and we'll get to those if you have questions over any of this. I'm happy to go into more detail. The first thing I wanted to really call out is that as states are kind of going through their day-to-day, the a change in federal direction or priority is not as disruptive as you might think. Like a Medicaid director is a change manager all of the time. There is not a time where they're just kind of sitting on their laurels and they're not having to navigate different policy priorities or leadership preferences, whether it's at the state level or the federal level. So Medicaid agencies and health departments, human services, they're experienced in change and being able to navigate some of these things. Having said that, there are varying levels of the sense of urgency based on which um, kind of vehicle or authority. Sarah hinted before that Medicaid has different avenues to try and address some of these upstream drivers. So the first thing that I would call out really is that if a state has an 1115 Medicaid waiver in which they use to go access some funds to put towards HRSN programs or provisions, when those authorities expire, really is the kind of dial, if you will, on the sense of urgency around, okay, what's next and how are we going to shift or navigate potentially a change from, well, that authority is currently in our 1115 waiver. The administration has hinted that maybe that's not the best place for it or just not the preferred place. States are already thinking about, okay, how do we shift those around? Are there other opportunities? Can we do the same or similar thing through an in lieu of service if we're a managed care state? A lot of that also then depends on where your waiver authority sits with regards to your procurement cycle. So one of the big things that state Medicaid does every so often is they rebid their managed care contracts. So when that occurs, you'll see priorities and different program structure kind of crop itself up. And really the 24 to 18 month previous to that managed care contract expiring is really where you start to see that. So when Sarah threw up the timeline before and it just kind of looked beautiful mind-ish, states are in that same space. Some states are going to be further along that timeline to where they're really having to deal with it kind of the here and now, while others are thinking about it in different ways. So the first bullet really is to highlight there isn't a 50 state approach, right? Each state is going to be in a totally different environment, and how they respond is going to be predicated on those particular timing elements and programmatic structures. The second bullet on this slide, and I apologize for the map being so small, it really is meant to be illustrative instead of hyper detailed, excuse me, is that many states already use ILOS or ILOS authority to do certain things. So when Sarah mentioned the Trump administration kind of shifting back away from the Biden waiver guidance to in lieu of services, that was kind of a to be expected. Trump won first term codified in lieu of service authority and kind of strengthened it a little bit as a we think this is kind of a good authority vehicle. So the map really is to illustrate. I know you can't read it, but the teal color are states that have in lieu of service authorities that don't have nutrition programs in them. The more tan or orange color is those that have ILOS authorities with approved nutrition services in them. Again, it's really meant to show that the authorities already exist. States are now going to be in the mode of tweaking those authorities to the extent that they want to use that as a pathway. Next slide, please. To kind of close out before Caroline gets a chance to really drive home the kind of evaluation and research pieces of this topic, which is so crucially important to all of the things that we're doing, a little bit of a crystal ball exercise on what's kind of upcoming. States, my estimation, states are really going to continue to leverage their managed care relationships. I mentioned before that the procurement cycles are kind of these lines in the sand where states have an opportunity to introduce or expand and grow programs that they're interested in seeing kind of move forward. So with that, you could see things like community and reinvestment requirements, which is effectively a state mandating to a managed care program, managed care plan. If you have operating margin over and above a certain threshold, some of those dollars need to come back to the communities that you're serving, and you need to invest them. Many plans across the country are exploring how to use those reinvestment dollars in different beneficial ways to the folks that they serve and the communities. That's an area where partnership with community-based organizations and nonprofits, other social services, can really like you can have multiplier effect in that the plan mandates, the state mandates it, plans have to abide by it. So there's kind of a ready flow. That doesn't take federal authority. That is not really subject to kind of federal whims or political battles, right? So that's another one. The same is true for value-added benefits. When a plan goes and applies for this Medicaid business, they need to be thinking about, okay, what are the next things that the state's going to be looking for that potentially they were invested in through a waiver. That waiver is not going to continue forward, but the plan saw return or the state saw a positive impact. That value-added benefit could be a differentiator as managed care plans approach the state for business. So that's another one to kind of look at that's a outside of the political spectrum and kind of the policy landscape. Um, Sarah teased this a little bit. The who matters just as much as the what. I think that, especially inside the waiver space, the really broad, sweeping, we're going to go after affordable housing for anyone who kind of comes and attests to the housing insecure. I would say that those types of initiatives are less likely than being really targeted with here is a population that is experiencing a disparate hardship with nutrition, transportation, childcare, workforce training, housing, whatever those things are, but being able to hone in on the population, I think there's probably more leeway in those initiatives than there is in some of the more previous broad scale issues. The last bullet, again, kind of highlights the just the crowded nature, the space that we're in. I mentioned there Utah, Oregon, Colorado, Arkansas, Arizona, Massachusetts, and California all have HRSN components inside waiver authorities that expire in the next 18 months. That's going to kind of be a watermark setting exercise to see which states are pushing which initiatives and which ones CMS is approving. The administration has already said we're going to kind of take a look at a case by case basis, and so it'll be interesting to see how some of those goes. The other thing with those waiver authorities expiring is that when a state approaches the feds around, we want to try this new innovative thing, they also have to propose how they're going to evaluate success. So when waivers start to expire, you're going to get some information out about how those programs were or were not effective. What results did you see? So there's also something to kind of fill up the evaluation and research buckets, which I think is nice. Sarah also mentioned Rural Health Transformation Program. As the states are rolling those programs out, they're going to want to align. CMS is going to want to see alignment between other programs and their rural health transformation funding so that there is that kind of sustainable linkage to more longer term programs and really being able to seed initiatives to kind of see them go. So I'll stop there, but like I said, I'm excited for this conversation and look forward to the Q&A, and we'll turn over to Caroline.
Great. Thank you so much. Yeah. Hi, everybody. So I'm Caroline Fichtenberg. I am at the University of California, San Francisco. I'm a co-director of the Research Dissemination and Evaluate the Social Interventions Research and Evaluation Network. It's great to be here today. Next slide. Before I dive in, just want to highlight who we are. So we're at the University of California, San Francisco. We do research. We also make research more easily available to practitioners through a big database of research that I'll have a link to at the end. And then we try to support researchers and practitioners connecting and learning from each other. Next slide. So today I think we skipped a slide. Is that possible? Yes, okay. I'm going to be talking today about some key new or new-ish research that I think everybody should be aware of in this space. Obviously, in 10 minutes, I can't cover everything. So I'm going to cover a few topics, but even within these topics, I'm not at all covering everything. But I'll start off with screening. So obviously there's been a lot of interest, next slide, in social risk screening. It's been something that CMS at one, was pushing, but other bodies are also encouraging. And some of the interesting conversations that are happening right now among researchers in this space is the question of, is screening necessary? Next slide, or click, please. And so, in other words, should we offer assistance only to people who screen positive, or should we basically be not screening and offering assistance to everybody? And there's a couple new studies that we featured in a recent webinar. One is the SECURE study that was conducted in Philadelphia at the Children's Hospital, led by Dr. Danielle Cullen, where they found that the WeCare tool, which is a pediatric social risk screening tool, missed 24% of people who wanted help. And then there was a similar study in Chicago, led by Dr. Jen Makalarski, where they used the AHC screening tool and found that it missed 40% of people who wanted help. And in both cases, the people who wanted help, that was measured by people basically being asked, are there any of these needs that you want to help with? And the people, way more people asked for help that way than screened positive in both of those cases. This is unpublished data at this point, but it definitely brings up this question that I think has been brewing and gives additional evidence around this question of, should we be focusing so much on screening, or should we perhaps be making resources available, asking anybody coming in, like, we could help you with any of these things. Let us know if you want help with any of these things, which might be a way that's a little bit less stigmatizing. There are pros and cons, obviously, because then you may not have the data you want to be able to look at the way risks are evolving, but ultimately this may be a more efficient way to offer assistance. I think that's still to be determined, but wanted to share this. Next, I'll talk about navigation. Next slide, please. So these are interventions that are providing navigation to help patients access resources to help with social needs. And obviously, like, the big study in this space is the Accountable Health Communities model that was implemented by CMS as part of a Centers for Medicare and Medicaid Innovation model. It ran from 2018 to 2022 or 3. The most recent report was published in 2024, and it found reductions that seem small in percentage, 4% reduction in total Medicaid, Medicare expenditures for fee-for-service Medicare and 3% for Medicaid, as well as some reductions in acute healthcare use. In Medicaid and Medicare, the patterns weren't exactly the same, but this, I would say, is kind of the big study. It was a randomized control trial. It happened in multiple places across the country. And I think we're still going to see results coming out about it as people continue to analyze this very rich source of data. Next slide. This may seem like a small impact, but in a report that Avalier Health put out earlier this year, the AHC model was actually the fourth best in terms of net benefit among all CMS innovation models to date. So that through 3 and 4% reduction in cost actually leads to substantial dollars given the number of people that this could affect. Now, one of the other things that was really interesting about the Accountable Health Communities model and a number of other studies have also been finding is that it's not entirely clear whether or not the impacts are happening of the navigation are happening because the needs are being addressed, or it's also because the navigator is providing kind of, social support that is helping the patient and also potentially client connections to healthcare. So on the next slide is a quote from somebody who participated in a navigation study that was run at UCSF by my colleagues, Dr. Gottlieb and Dr. Hessler-Jones, that highlights the way in which, and this has happened, and we've heard this in a number of studies, that having somebody that helps patients navigate the system, but even just have a sense that there's somebody there who cares, maybe also having an impact. Still TBD about that in terms of really strong, rigorous study looking at that, but I think that's an interesting idea. Next slide. I'm going to talk now about some of the upstream driver programs in Medicaid that Carter was just referencing. There are 2 states where we have some recent evidence. One is North Carolina with their Healthy Opportunities pilots. So these were 3 pilots in 3 regions in North Carolina that provided, paid for some nutrition services, some housing assistance, some transportation assistance, and some interpersonal violence or toxic stress assistance. And an evaluation conducted by researchers at University of California that was published earlier this year found, and this was a control, they controlled what happened in those 3 counties to what happened in other parts of the state, and found a substantial reduction in ED visits. So 6 ED visits per month per 1,000 members less among the HOP participants, Healthy Opportunities Pilots participants, fewer hospitalizations, and that translated to reductions in cost, even counting the costs of providing the services of $85,000 per month per 1,000 recipients. So substantial, again, or meaningful cost savings from the Healthy Opportunities pilots in North Carolina that address this range of needs. We don't know which seems to have had the best impact, et cetera, yet. That's something I think or the biggest impact of these services, or if it's the combination. So we're hoping to see more analysis come out of that model. Next, I'll shift to Massachusetts. So Massachusetts Flexible Services Program next has provided nutrition supports. And there was a recent study just this year that found that across the state in the 17 ACOs that are doing this, there were reductions in hospitalization, reductions in emergency department use, however, no cost differences. So interesting findings there. And then looking at the impact of nutrition and housing supports, although just in the Boston area with 1 ACO, another study also published this year found no 1-year changes in food or housing insecurity, diet stress, or acute healthcare use. So again, ED visits and hospitalizations. So some conflicting results here, different populations, different studies, analyses being done differently. And so I think there's still some questions there about the impacts of Massachusetts Flexible Services Program. Next, I'll talk now, I'll finish with some of research about food as medicine programs. So food as medicine encompasses, on the left, medically tailored meals, medically tailored groceries, and produce prescriptions. Those are the 3 that people tend to think about as food as medicine. And there have been some great recent reviews of research in this space. There's a lot of research on these interventions. This slide provides kind of a short summary based on a 2024 Aspen Institute Food as Medicine Research Action Plan that's linked at the bottom here. So there are benefits seen with all three of these interventions. Medically tailored meals definitely has the strongest evidence. Medically tailored groceries probably the least at this point. Produce prescriptions has a lot of evidence, but not necessarily the highest quality evidence. So I think that there's evidence of benefits, but there's still a number of questions and some mixed results. I think there's still a lot of questions around potential dose, which interventions might work best for which people, for which outcomes, et cetera. But this is a great place to focus. Obviously, right now, given the interest from the health secretary in food and the impact of nutrition on health, and the fact that there's a lot of good evidence here. Next slide. There are also some really great estimates of the potential benefits of expanding food as medicine strategies nationwide. So here on the left is expanding medically tailored meals to people with complex chronic disease, plus limited instrumental activities of daily living nationwide. The savings that it could lead to, the number of fewer hospitalizations. And then the same on the right for produce prescriptions among people with diabetes and food insecurity. And in the next slide, there's also a recent analysis that looked at state level impacts of implementation of produce prescriptions. So these, where they found that there were net cost savings in 43 out of 50 states. And it was highly cost effective in 49 out of 50 states. This is for produce prescriptions. So these are great resources to go to if you're looking for some data about potential cost impacts or estimates of impacts at the state level or nationally. Next slide, I think, is my last one. So just summing up this very quick tour of some of the evidence in this space. Screening tools may not be identifying everyone who wants assistance. So there are a lot of people thinking about alternative ways of offering assistance just to kind of everybody and letting people self-select. Evidence of benefits for navigation, and I mentioned for moderately complex patients here because the AHC was not for like the most complex patients, and we know that there was the Camden Coalition study that came out a few years ago that made a big splash in really complex patients and that didn't found benefits. So I think the navigation right now the benefits are strongest in this kind of moderately complex patient population. Medicaid social drivers of program, there's some encouraging results, particularly in North Carolina, more mixed in Massachusetts, but we're hopefully going to see a lot more evaluations come out, as Carter mentioned, in the next few years. And then food as medicine, solid evidence of benefits, and again, a great place to be focusing given the priorities of the administration currently. So I'll stop there. And oh no, I'll say one more thing, which is if you want to dig into any of this evidence, we have this thing on our website called the Evidence and Resource Library. It is a searchable database of all sorts of, all the research in the space, as well as implementation tools, updated monthly and just free and available to be searched. And also, if you want to stay on top of the literature, feel free to sign up for our newsletter because every month we send out the latest research. Lovely to present this, and I look forward to the discussion.
Thank you, Caroline. That was incredibly helpful, and we appreciate the overview. You've received a number of questions on your screening topic, and so I want to kind of go over those and make sure those get answered for our audience members. So there was a question about, is there a specific area in which the studies were trying to figure out for screening? Similarly, was it managed care or just fee for service?
So the first
Can you
question, I'm
describe?
not sure if the person could, when they say a specific area, as in like a specific need, if it's about like, food versus
That's what that
housing
means.
versus transportation, those two studies found that there were missing people across all of the needs. I think that it was higher for some needs than others, and I don't remember exactly which ones. Um, if I recall, actually, I think it might have been higher around food, and financial insecurity, maybe. And it's important to remember that I should have mentioned this. This was in pediatric population, so caregivers of children who are probably, some of the most leery, along with people who don't have, along with immigrants, I think, about answering these kinds of questions. Um, but I hope that answers that question. If it doesn't, please chat again or write something else in. Um, in terms of the including managed care or just fee for service, was this related to the screening? Because this was not limited to any particular. I'm sorry. The studies on the screening were in pediatric populations, so not Medicare. So it did not. It was not managed care or fee for service. If it was that was a question about Medicare, it did not. It was not limited to people who are on Medicaid, although chances are a good number of people who were in the study were on Medicaid. And I don't know if it was managed care or fee for service in terms of Medicaid. I think it included both. Um, if that question wasn't about screening, please write back in. And then there's a question about the screening tool miss rate dependent on the seasonal weather. That is a great question. I don't know. Um, I that did not come up, so I don't know, and that would be an interesting question to answer. I'll see if I can get the answer to that after the webinar.
So that might be an area where more research is needed, possibly.
Yes, yes, or just asking the researchers if they noticed any seasonal differences. They didn't mention it, and my guess is probably not. Um, but obviously there might be differences in needs at different times of year, particularly in parts of the country that get really hot or cold at different times of year. And also in the summer versus during the year in terms of meals for children. Okay. Do you want me to
And
keep going down
then,
questions or?
yeah, we have for anyone, I think, Caroline, you would be great to answer this too. I think we have a couple of questions on how do produce prescriptions work?
Yeah. So
What
I'm
does that look
happy
like?
to give a really quick overview, but if there's anybody in the audience who's an expert on that, please, feel free to chat in as well or write something in the Q&A. So a produce prescription is basically giving people money or directly giving them I think it can work in different ways, and now I'm hesitating. But I think in general, it's giving people some money so that they can go buy fruits and vegetables. As opposed to, I think, giving people food directly would be medically tailored groceries. So, for example, providing a box of fruit and vegetables that get delivered to people's homes. Then you're talking about medically tailored groceries. The fruit and vegetable prescriptions are oftentimes vouchers for farmers markets. So where you can go and get, fresh fruits and vegetables locally, but not exclusively. It's also sometimes like, yeah, I think there's a variety of ways of doing it. If someone in the audience, I don't know, Carter, you're nodding your head. If
Uh,
you want to
yeah,
share
I was
more.
just going to say the design of it is varied, as you mentioned, but in effect, it is here's the ability to go get it. And whether it is in the form of, you know, EBT credit or voucher or actual sheet of paper that you take to farmers market or nonprofit or wherever. But in effect, it is you can go here and get food, as opposed to medically tailored or delivered, which is here's the food.
Thank you. That was a lot clearer than what I just shared.
You got there.
Another question for maybe any of our panelists is substance abuse regarded as a social determinant? So I know we've talked a little bit about, focusing on specific populations as opposed to kind of the broader population of that may identify as, having a need for a social need that impacts their health. Is substance abuse considered that?
I want to give a really wonky answer that some on this call will very much appreciate and other will roll their eyes. Um, when I referred to SUD or even severely mentally ill or other kind of mental health diagnoses, I was referring to it as an eligibility pathway for programs. So the diagnosis, while an acknowledgement of the like there are conditions and things that come along with it, the context with which I spoke about it in terms of a population, it's how Medicaid identifies those individuals as an eligibility group that can receive a certain subset of benefits or not. The question as to whether that is also a determinant of health, I think universally is yes, but how is it approached in terms of intervention or benefit is kind of a separate and different question. So to clarify the like, yes, and would be my final answer.
And from kind of a researcher lens, working, so um, social determinants of health at their root are meant, the concept is meant to capture non-medical, non-biological factors that affect health. So I think in my space, we would tend to consider substance use disorder as a medical condition, but obviously strongly influenced by a number of non-medical drivers of health. So we wouldn't put it in the social determinants of health bucket, but I know that some people do because it's on that border that people like mental health don't always don't always put it exactly in the same bucket as like other physical health conditions, although we would.
Thanks. Next question. Any granular evidence data on how food as medicine efforts help with controlling
Yes.
HTN? Do you know what
Yes,
HTN is? Okay.
I cannot tell you exactly what it is because there are just a lot of studies in this area, and I'm not exactly a specialist on that. But I will put several links in the chat here if I can send it to everybody or not. Um, I'll put it in the chat and hopefully somebody can send it out to everybody. They're also linked in this slide deck. But yes, there's good evidence related to hypertension.
I was going to say, just to clarify, I think we're using the medical sort of coding term there, HTN for hypertension,
Oh,
right?
yes.
Yeah,
Sorry.
okay.
Yes, hypertension. Yeah.
And as a reminder, you mentioned, Caroline, that some of this information is in the slides, which we will send out to everyone who registered for the webinar. All right. Was the screening method used, did it analyze such as were they interviewed or just responded
So
to
this
an
is
electronic survey?
on the screening results. So in one study, they were responding to questions on their smartphone. In another, I think in both cases, it was electronic. Sorry, I'm having a little trouble remembering, but I'm happy to also check that. And maybe by the end of the webinar, I can double check that. But I think it was mostly through electronic surveys on people's phones.
We are really putting you on the spot for all the details of these studies, so thank you for that. Last question that's in the chat, and then we have a couple of more to go through. Are there any studies about the importance of mobility adaptive services or mobility adaptive devices?
I don't know the answer to that question. My guess is that there probably are. It is not an area that we at Siren focus on those, so I cannot say for sure. If anybody else in the audience has knowledge about that, feel free to speak up.
Great.
But
And
also
then,
happy to do a quick look after the webinar if that's helpful.
yeah. Um, and reminder, if you have any questions, feel free to put them in the Q&A. One question for all of our panelists is there's been a recent focus on making America healthy again, or the MAHA kind of movement. Can you talk about how this movement is impacting the federal and state efforts to screen for and address upstream drivers of health?
I'm happy to start, and then would love to hear from Sarah and Caroline as well, because I think the perspectives are varied. Again, so much of it depends on from a state view where you find yourself on that like adoption curve. So if states are already engaged and have established nutrition assistance or linked programs, um, the impact to those states is going to be different than if somebody was on the fence and has not gotten into those programs quite yet. And so I think that it always helps whenever evidence is coming out, and Caroline and I have both mentioned like there is a lot of good information that's coming out on the benefits here. And so the MAHA agenda, especially as it relates to nutrition, I think is pretty, I don't know, pardon the pun, but ripe with opportunity for different action from the state perspective.
And I would concur. I mean, I think with that from an evidence perspective, the food as medicine range of interventions, I think is a potentially a space where I could imagine there's a lot of alignment with federal health priorities. And I think I would be remiss if I didn't mention that the food as medicine is thought to be a continuum that also includes things like making sure people who are eligible are referred to available programs like WIC and SNAP, et cetera. But yeah, I think in the healthcare space, the medically tailored meals, medically tailored groceries, food prescriptions are very well aligned right now. And I think also, I mean, I'm just reiterating what Carter was saying, more generally talking about kind of the root causes of health issues seems to be something that that is politically of interest right now.
Thanks. We have another question in the chat. Was HUD involved in efforts by CMS during the Biden administration to encourage the use of 1115 waivers for addressing housing insecurity? The broader curiosity here is at the federal level to the extent which other agencies are involved in efforts related to SDOH.
Laura, I can take that one. Yeah, it's a great point. During the Biden administration, you did see a lot of, it started with coordination at the HHS level and moved up to the White House level with their SDOH action plan. And as is typical for an action plan like that comes from the White House, they sort of called on each of the different agencies of the federal government to say, how are you doing your part on this issue? And so they did have a lot of coordination between HHS and HUD as well as other agencies. You know, inherent in all of this is the tension that the healthcare system has a lot of pressures on it and there's a lot of constraints, and particularly right now. So we can only ask so much of the healthcare system. So we really have to look at the different sort of pots of money and streams of not just federal funding sources, but state sources and nonprofit sources and other ways that we might get the money into the system to address these needs. So we did see a lot of that, of coordination, looking at, okay, if we can't use just Medicaid dollars or Medicare dollars for all of this, how are we going to work with our other existing programs and collaborate better? I think it is a time of a lot of change right now and of some different shifting in priorities. So we haven't seen as much of this right now, but we have seen some recent shifting of some of the HUD programs to focus a little bit more on the transition side of thing and not the supportive housing and the actual payment for the housing services. So I do think the posture is changing a little bit here in this administration, and less clear how HHS is going to work, if at all, with the other agencies, particularly in the waiver context. As we talked about at the very beginning here, this administration has said it will entertain case by case waivers. So if states want to do innovative things and they want to pool together funding on their own from their different federal funding streams or things at the state level, I think that's the opportunity. I think we're less likely to see kind of at the federal level the guidance coming down saying you're welcome to do this. But if from the bottom up we see states or MCOs working with their states saying here's things we want to do, I think that's where we're more likely to be successful. And Carter, we were talking about this before this about what's happening in Ohio. That might be a good example if you could touch on that.
Yeah, so Ohio has a requirement around community reinvestment that I had mentioned. Many states and more are bringing online. The Association of Health Plans in Ohio has actually pulled together a fund to pool those reinvestment dollars across all the different plans. And they have regional committees that then get together to test new benefits using those community reinvestment dollars. And the premise there really being that it's driven again through a state initiative that doesn't need a ton of federal dollar or federal authority. It's really being able to go and leverage dollars that are meant to go back into the community to test something. So it's like a little micro lab, which is nice. The premise there being that part of the charge to these regional advisories in Ohio is that they are meant to take a look at things that could be spun back into waiver or ILOS services or things like that to make sure that it sustains beyond, initial investment. So there's a lot of things like that that are kind of up and running as well. It's a really neat opportunity. If anybody has questions about Ohio, I'm happy to do that. You can find me after the webinar.
Thanks, Carter. And we just have a little bit of time left. And so I know that we're not going to be able to get to all of the questions in the chat. And I hope you reach out to our panelists and our experts on today's call. But since we just have a little bit of time left, I want to ask the panelists, since you've each shared a lot of helpful information today, and we have had a lot of questions, if you just had one key takeaway for our stakeholders from today's webinar, what message would you want them to walk away with?
I'll start since I went first. Going back to where we started, some of the federal incentives and permissions are changing, but that does not mean the work is stopping. And looking at the members of our NASDOH coalition and other healthcare and community-based organizations, stakeholders we're working with, a lot of the infrastructure has been put in place to address upstream drivers. And it may take a little bit more creativity now, and it may take a bottom-up approach, but there's still the ability to work on these issues together.
Yeah, I think from my perspective and really kind of keeping focus on the state landscapes, there's definitely a lot of like anytime there's big shifts or change, there's a tendency to flip this or shift down, gear back to a wait and see. I think that's a misstep, candidly. And if nobody's real confident about, well, what's the first step? I would lean into and strengthen or initiate relationships with your managed care plans in the community. They're going to be the ones who are kind of front and center no matter what. And so being able to get in on those levels and strengthen those relationships for partners, I think is a safe step, right? That's one that everybody can go and kind of double down on efforts there today, and there's just zero downside.
Great. And I'll just say that from the evidence side of things, there is a lot of good, solid evidence to base to use to develop programs. And I think especially that look at things like cost and utilization, which are often the things that that's not the only thing that matters, but it's often the things that can move decision makers. So yeah, I would echo that I don't think this is the time to pull back. That this is a great time to continue testing, trying things out, and finding what works for the populations that you're working with.
Great. Well, thank you again for joining today's webinar, and thank you to each one of our panelists for the information you shared. If you'd like any more information on the topics discussed during today's webinar, we encourage you to visit NASDOH, NASDOH.org, or reach out to any one of our experts on the call today. Thank you again, and we hope you have a wonderful holiday season.